So a little bit, I guess I should do a little bit of a bio. Some speakers have done it. I trained for dental school at the University of Illinois, Chicago, and then for orthodontics at the University of North Carolina, Chapel Hill. I'm currently a professor at Indiana University in the Department of Orthodontics and Oral-Facial Genetics. So today we're going to talk about managing the impact of unerupted teeth, and many who have heard me speak know that I talk about those disorders that often have a very direct genetic link. And every time I speak, I try to curate a set of records and cases that I have not shown before. Sometimes I make comparisons to those that I have. And by the virtue of having published with very fascinating colleagues like people in the audience here, sometimes I get cases sent to me and they are very happy for me to share. So some of the cases today will be those that I'm sharing from others. And I have no conflict of interest with or involvement in any organization or entity with any financial interest or non-financial interest in the subject matter discussed. And I always like to give some objectives, even though sometimes I don't feel like I'm following them. And I put my two baby girls who are now adults pictures in there because they're showing their teeth. And when you look at little kids' teeth, they're always so cute. And, you never know what's underlying that cute smile. But today we're going to talk about some of the stages of eruptions just to give a framework. And then we're going to distinguish between different types of eruption failure that you may see in your practice. And I'm going to share some novel thoughts. Some, unfortunately, because of the rarity, may be more anecdotal, and it's not my usual evidence-based way to do things. But I think it's important that we consider all the possibilities. So we're going to do that today. And we'll start off with a blast from the past. Some of you may recall the AAO was in New Orleans 10 years ago, and these are just some individuals who I have trained along the way who were there, and they're all doing amazing things now. The bottom picture is Bourbon Street. And if you somehow come and meet me afterwards, you can ask me what's the story behind that, because there's a story, but the moral is don't go to Bourbon Street at what might be an ungodly hour. So I learned that, and you can ask more about that later. But the other blast from the past, from 2014, is a case that one of the many that I get from colleagues, and I did block the name out, but this, I think Dr. Sonny Long, who's an orthodontist in Charlotte, probably wouldn't mind if I shared. He sent me a patient and said, Sylvia, I don't know if this is easily readable, I saw a 6.7-year-old new patient this morning and thought you might be interested in seeing his records. There is no family history. He knows that that's important for me to determine right away. Of eruption disorders. Hope all is well. Warm regards. Makes it sound like it's going to be a piece of cake. Sorry. Oh, yes. And so here is the pan. And I ask those of you in the audience for this patient in your mind's eye to think about, what do you think of this? How would you diagnose it? And then once you diagnose, how would you treat it? I don't have the polling slides that I sometimes have, but just keep it in your mind's eye. You can see that the first molars, the 6-year molars, are not erupted, but there are primary teeth present. And so again, this is probably not very readable, but Dr. Prophet, who was a very close mentor in these studies of eruption failure, would always go over cases with me. And so I told him, hi again. I met with Prof, and he and I both agreed that we can't be certain of the fate of patient's name, permanent teeth yet, but the primary molar certainly appears ankylosed. One approach we agreed on is to extract the primary first molars. You likely don't need to worry about space maintenance since the second molars appears, ankylosis well, the primary. You can then use the next 12 months to observe the progress or lack thereof for the permanent first molars. It seems too early to extract the first molars now, but it may be necessary in the not too distant future. The primary second molars will likely need to be extracted as well, but that can be timed. So, in summary, extract primary first molars, monitor the progress of the permanent first molars, and consider extraction of the permanent first molars. So what did we know in 2014? And again, why am I flashing back as I build the story of management of eruption failure? Well, we did already know in 2014 that there's some eruption failure that's caused by a gene, certainly. PFE is one of those. And when you think about it, so is CCD, which is by the RUNX2 gene. These are genes that cause a problem. But some unerupted teeth could have a mechanical obstruction. Some of them have a primary failure of eruption. And if it's PFE, it can be unilateral or bilateral. And it's known that it's hard to distinguish between ankylosis, delayed eruption, and PFE. The three of those are difficult to tell from one another. But we know that there is a mutation or mutations in a gene called PTH1R, and there are different types of PFE with varying clinical presentation. As from the slide here, you can see there's type 1 and there's type 2, which is hard sometimes to discern from other types of eruption problems. But what we do know, and again, I don't have to preach to the choir that is here, that teeth that are affected by PFE will not respond to orthodontic forces. We also conjectured around that time, I shouldn't say conjecture, we had an evidence-based study that showed us that the first molar being affected is a hallmark of determining whether you have PFE or not. We just looked at many cases where second molars were impacted and they were mesioangular, and that is not ever the hallmark of PFE. But we figured from a very robust cohort that, or we were able to conclude that the first molar, which has a pathway that's clear, is a hallmark of PFE. And what happened since 2014, and Dr. Juanita Ono is doing some very eloquent studies that are molecular and also in a mouse model, but they really confirmed that not only is this knockout of PTH1R receptor responsible for tooth root formation that's normal, but it's also clear in the mouse model that it is specific to molars, so you don't see this in incisors. So that's another key in our rubric of how we can determine whether something is PFE or not. You would not see it in anterior teeth. And so this study is important in that, you know, it is a mouse model, but it is giving us cues to what we might want to look for in root formation. However, we have not yet seen root formation that is significantly and consistently abnormal. But it was good information. And so today I'm going to juxtapose again with a case you haven't seen before, for sure, if you've heard me speak. Maybe one case that you have. But I'm going to juxtapose this. It's a cautionary tale of two cases, both mixed dentition, young, and actually probably not mixed dentition for the first one. The top most on the slide is a 5-year-old male, and the bottom is an 8-year-old female. Now those two ages are not the same developmentally or otherwise, but these cases are important to juxtapose. And so anytime we see a case, the first thing we should figure out is there a family history? Neither of these had a family history. What's going on with the primary molars? Are they ankylosed? How did you determine that? Did you tap on them, or did you have visual cues to the occlusal plane? And are you certain that there's never been a mechanical obstruction historically or otherwise? And sometimes, as I later learned, the tongue is a mechanical obstruction, and it can be. But first, let's review for all the learners still in the room. We want to think about the two aspects of eruption, and we're not going to go over the whole thing, but just pre-emergent eruption, sometimes called pre-eruptive, and post-emergent. In pre-emergent, the crown of a tooth is formed, and there is sort of a slow labial drift of the tooth follicle within the bone. The root formation accompanies the eruptive movement. You absolutely have to have resorption of bone and the primary roots in order for this system to work. And those conditions that have fibrous gingiva can be known to impede eruption. And Dr. Prophet talked about in his textbook that this requires a propulsive force in order to be successful. That's pre-emergent. Post-emergent is after emergence in the mouth, and the tooth has this experience of rapid eruption, and it approaches the occlusal level. Now this is followed by a phase of slow eruption termed juvenile occlusal equilibrium, and the teeth from that point forward erupt at a rate that's coincidence with the rate of vertical growth in the ramus. So again, on your rubric, it's Monday morning, you're seeing patients, you have to know the difference is two conditions can be juxtaposed, that is, for instance, or three conditions, cleidocranial dysplasia and osteopetrosis, you don't have a clear path. Remember that the path has to be clear, which means is essentially that the resorption of bone has to have occurred. In PFE, it's interesting because you do have a clear path, but you don't have this propulsive force. And in that mouse model that Dr. Ono and team have been working on, they have shown that the PDL is not formed normally. So we already know that the PDL is the source of this force that's not present in PFE. Now, this is a slide that many of you have seen before, and we're going to kind of deconstruct it. When you think about clinical findings, diagnosis, and treatment decisions, always asking, is the pathway clear? Is there a barrier? Is there a first molar affected? If we really kind of drill down on this and ask ourselves, well, if there's a permanent first molar affected, yes. Could it be primary failure of eruption? It could be. It still could be no. Not many people are going to have the wherewithal and the access to have a PTH1R genetic test. But we know that if we have determined it's PFE, then the funnel has narrowed in terms of what it is that we can and can't do. One of the least popular things to do is to treat the case partially. A lot of people don't find that satisfying, but remember, if you use a continuous arch wire, it will cause intrusion of the adjacent teeth. So you could treat sort of a segment. And then there's also osteotomies or posterior restorations. And again, I mentioned that I have many good colleagues that share cases, and in Charlotte, North Carolina, there's a surgeon, Dr. Myron Tucker and team. He's now retired, but he works closely with Sonny Long, who also shares cases. And Dr. Tucker has published pretty well in terms of oral surgery and all types of conditions, approaches. Not as much on eruption failure. This is a very enigmatic area. But he did share that, even though there's not enough data really to understand, he did share that he uses the approach of osteotomies. And in just a snippet of a patient shown here where you don't see all the records, he in fact talked about using regional acceleratory phenomena because of the noxious stimuli of having the traumatic separation of the bone, that accelerates the normal vital tissue processes and turnover, and that could last for about 4 months. And what happens at that point is, and this is just a close-up, what happens at that point is you use intermaxillary elastics, and the intermaxillary elastics immediately following the procedure. 8 weeks post-surgery, the first thing I know all the orthodontists in the room are thinking, that's not a good finish, but you have to understand from whence the patient came. There's the option of having no occluding teeth in the posterior or some that is not ideally positioned in the AP plane of space. So the short-term results are promising for some because this is better than where it was started. But what about another approach? And again, these records are from Dr. Tucker and his team, so I don't have all of the tracings. But if we look at the images before us, we can see that there are lateral open bites bilaterally. And there are other facial skeletal relationships, such as kind of a bimaxillary retrusion. But overall, we're seeing that the posterior teeth are not in occlusion. And some of that on the right side is due to wear. And then, of course, there was an extraction, which I was not told why. But they are clearly not in occlusion. So the oral surgeon commented that he treated this with mandibular repositioning. Not ideal, but he talked about the disadvantage of doing osteotomies in the mandible and how that may actually sometimes cause you to sort of lose control of those mandibular segments, and they may kind of roll in lingually. So he didn't want to do that. So he did a compromise treatment plan, and because the probability of fracture and the lingual sort of rolling in were enough that he leaned away from that approach. And so 28-year-old male actually in this case had the mandible repositioned, which seems like a very aggressive and maybe counter what we might think about doing. But the result after fixation is this. As you can see on the pan, just loosely, you can see that there is some now occlusion. And what was surprising to me is that 5 years out, there's still some stability. This is very anecdotal, and again, I'm very focused on evidence-based studies. However, because primary failure of eruption and other disorders such as this are so rare, people don't have enough of a cohort to actually do a cohort study. So there's still not enough data to really understand, can we expect this same result? And I'm not showing the facial pictures to avoid sort of a HIPAA maybe confusion. So still not enough data to understand, but 5 years later, this man, a young man at the time, has an occlusion that he can function on. What about the first case that I showed you from 2014? It's a 5-year-old, started out 5 years old. What are we going to do with that case, and what do we even think about the diagnosis? Well, we thought it was PFE, and this was not using a genetic test. Everyone didn't pursue that. And we thought, as I shared earlier, that, well, maybe you should observe this and see how it goes, and or start extracting primary teeth. Now, it looks like extracting primary teeth was not done as we had advised, but here is the progress, and I'm going to move forward very quickly. Looking at his Ceph, you can see clearly the vertical defect that is created by the posterior open bite, class 2, deep, very deep bite. And so this is age 6.7. So this is later. It doesn't look a lot different because he's not experiencing much eruption, but this actually is later. And this is still how he looks. The decision was not made to take out the primary first molar and primary second molar as we had suggested. And so, but this is how he's evolving. And if you flash forward about 7-ish years, you can see there's some eruption of some teeth, presumably those that are not in an affected part of the arch. Remember, PFE can occur in one quadrant. It can occur in both quadrants. It can be upper, lower, both, etc. But at age 13, we can see not only are we still manifesting this eruption failure, especially in the lower right segment, but we also see the tongue, which for anything that would have been normal is probably going to create a different barrier. So by the time the patient is 13, we don't have enough eruption of really any of the teeth posteriorly. And the left is affected in a less severe way, but still a very significant open bite. The patient's AP is still the same, which is class 2, and now seems even deeper than it was. So this particular orthodontist has done, on occasion, vertical tongue cribs. And that's what you're looking at now, the combination of an expander and a vertical tongue crib, because that tongue in the way certainly would exacerbate whatever was the problem, but maybe the problem is solely due to the tongue in theory, but we're going to talk about why that could or could not be. So by the time the patient was 14 and a half, had worn this vertical tongue crib for at least 6 months, and now a year, and you can see some improvement in the upper right, but really limited to that, which means that maybe the tongue secondarily was a part of what caused the eruption failure, but what primarily caused the eruption failure, which is likely primary failure of eruption, is still a problem. And the bite continues to collapse in this patient. And so by the time the patient is 16, this is kind of where this story ends. And actually this is now, because remember I said in 2014, that's when we got the records. So it's 2024. This is now today. And the treatment decision had been not to take out permanent first molars, but it used to be something that Dr. Prophet recommended a lot, take out the permanent first molars, because even if they have PFE and the second molars are affected, maybe by virtue of having the edentulous space and the regional acceleratory phenomena, it might have some movement and activity. And so the treatment decision, which was monitor or observe, how did that work out? In this case, maybe that was absolutely the best it could be. But you might ask, why would he even consider such a treatment? Well, let's consider what was different in this case. Here's another case, the one I showed you in the beginning, the 8-year-old, right side open bite that seems to, 4 years later, have gotten worse. And 5 years later, it has not gotten really better. Not affected on the left side. A vertical crib was placed. and voila, it got better. So my question, what was different? Why did that work for that patient and not the first patient? What is the difference? The difference, if you really look at these cases carefully, as I had even not done myself, sure, we might suspect that this is ankylosed in some way. Maybe this was, but this is clearly significantly ankylosed. And what we have found in our own assessment of these cases is that when you have an ankylosed primary tooth and a manifestation of permanent teeth, primary failure of eruption, or what looks like primary failure of eruption, you likely have the primary ankylosed tooth as the indicator that PFE is coming. Now, be careful with that. It doesn't mean that everything that's ankylosed is going to be PFE, but you can see the difference in those two cases, and one was striking, and that's what we found. And so the bottom line in our little rubric, permanent or primary first molar affected, should be what you're asking. So when we go back to this rubric that we deconstructed, when you say, is the pathway clear, if you have access to records, ask, was a primary molar ankylosed? Is a permanent first molar affected? And also, in a treatment decision, instead of simply observing or monitoring, again, the suggestion had been made by Dr. Prophet, who first described this, why not take out that permanent first molar time just prior to second molar eruption, and maybe you will get some drift that improves the situation. So the take-home message is that in both of these cases, neither had a family history. One, it turns out, as you see, did not have PFE. One, even though there was no genetic test done and there was no family history, did have what is clearly PFE. The take-home message, as we already know, proper diagnosis equals proper treatment, and we do not want to use a continuous arch wire. But the more anecdotal part of this is the osteotomies. The treatment options with osteotomies can be very aggressive, and we don't have consistent outcomes. But for some people, it gives them absolute and utter relief and quality of life improvement. Carefully assessing the primary molars may distinguish clinical cases that can respond to a vertical tongue crib. And I have other examples of cases that have responded to a vertical tongue crib, which is not really a very popular thing. And finally, extraction of a permanent first molar, which I always thought seemed so severe, but really the sort of submersion from the affected segment, it may be better off in some cases at least trying to take out the first molar and see if you can, by virtue of some acceleratory phenomena, get the second molar to come in a little better. Finally, in orthodontics, we are constantly looking at certain topics that are more controversial, and sometimes it seems like 20 years or 10 years or 50 years, we're still not sure what the answer is. But I'm sharing this quote that I had shared in an interview earlier this year, and that is that we must develop the spiritual and professional discipline of discerning small, incremental positive change that is happening every day. We continue to evolve as a specialty in a very good way. And I thought about this quote after I typed it out, that who better to be good at discerning small, incremental positive changes than orthodontists, because that's what we do. So we can never grow weary about whether the answers are right before us on how to solve an impacted second molar or impacted canine or PFE. We may not get there quickly, but we will get there one day. So with that, I say thank you. I want to acknowledge all those people who have helped me along the way with, so some of the funding is very old funding, but I put it there because it's what contributed to these studies. And all the people who have contributed to various studies, some that were, some of the cases that are here. I encourage everyone to consider attending the COAST conference, which will be in October. I won't be there. I will be with Indiana University interviewing residents or future residents, but I welcome people to consider going there. And again, I thank you for your attention and all who stayed to hear. Thank you.